We have the next presentation, practices in the wards towards patient safety in OR. We have two presenters for this particular topic, Dr. Vivek and Dr. Tony. Now we have the first presentation, Dr. Vivek. Dr. Vivek is a professor of neurosurgery and also deputy medical superintendent who is in charge of the operation theatre. And he is a fellow in neurosurgery in Royal Adelaide Hospital, Australia. And he has done his MBBS, FRCSI and MCH neurosurgery. And he is also a fellow of neurosurgery, in spinal neurosurgery in Toronto, Canada. And he has special awards, 2005 Sontag International Fellowship Award, from ANS CNS Joint Section on Disorders of the Spine and Peripheral Nerves. He has a number of publications and has written chapters like 20 and 2. And we are very happy Dr. Vivek is in our midst to talk to us about the practices in OR as a surgeon. Yes, Dr. Vivek.
Thank you, ma'am. Respected chairperson, ladies and gentlemen, I would like to thank the organizers for giving me this opportunity to give this presentation. Now, is it possible to operate on a wrong patient? To get some kind of scientific data is actually quite difficult. However, unfortunately the answer is yes. This is a study from an insurance company's database of about 6,000 doctors, and about 27,000 of reports of adverse occurrences were given, and all of these were self-reported. And so the actual incidence is much higher than this. And among these, 25 wrong patient procedures were done. Thankfully, there were no deaths, but significant harm was done in 5 of them. And if you look at it, 3 healthy patients had unnecessary prostatectomies because of a mix-up in the pathology lab. Vitrectomy done in a wrong patient because 2 patients with the same name were there in the ophthalmologist office. A myringotomy is done in a child who actually required an adenoidectomy because the wrong patient was wheeled into theatre. Similarly, a procedure on a wrong site or a side was done in about 107, and 38 of these were significantly harmful. And if you look at the list, it goes down all specialties: spine, a wrong side chest tube, medicine, vascular, bowel resection, orthopedic, ovarian surgery, ophthalmology, neurosurgery, urology, radiotherapy, and maxillofacial surgery. This can happen in any specialty. And what is the cause? If you see, it is errors in diagnosis and errors in communication, which was significantly more in patients in surgeries for the wrong patient, and inadequate planning and lack of timeout being performed, which was significantly more in the wrong site patient. And you will realize that no amount of technology is going to solve this problem for us. So the WHO has come out with a surgical safety checklist for surgeons, which is easily available on the net. And the interesting things is that they have pointed out that this is not a comprehensive checklist, and it is important for each hospital to modify it to their needs. Additions can be made, but the simpler the checklist is, the more likely it is to be effective and followed. They also correctly emphasize that the surgeon alone cannot be the lone person responsible for patient safety, as the previous speaker has also mentioned. Now, to start off, it may be important to have one person who administers the checklist, provided that person is sensitive and doesn't be too abrasive and rub people off, and then in which case the buy-in will not be there. But once the checklist is done often enough and people know what is to be done, slowly the role of that person will reduce, and this will be done by all those involved in the OR. So this is the surgical safety checklist developed by WHO. And the first portion is a sign-in, and then you have a timeout, and then a sign-out. The sign is before induction of anesthesia, where the patient had identity, site, procedure, consent, marking of the site, the anesthesia safety checklist, which Dr. Tony will explain, a pulse oximeter, are there any allergies, airway problems, and likely blood loss are looked at. Then you have a timeout before the skin incision. Now here they say that the team members are to introduce themselves by name and role. And then again a checklist of patient identity, site, procedure, and a review of all the possible problems, whether antibiotics have been given, and is adequate radiology being displayed. And then finally the sign out, with again going through the procedure, looking at the instruments, whether they were sterile or not, biopsy specimen labeled, etc. Now, just coming to what we do in our ward, and especially in our neurosurgery unit, the day before the surgery, ideally the doctor who will be in the operating theater, but this is not always possible, goes through the patient and sees whether the patient requires a surgery. Then they look at the radiology and see whether there's a correlation, and the side of the surgery is marked. For us, in a craniotomy, it's usually the ear which is marked, and we use gentian violet. Permanent marker can also be used. An informed consent is taken without frightening the patient, and documentation, signature with name and employment number of the doctor taking the consent, and the relative is also explained, because we have had a situation where the patient had a problem post-op, was in ICU, couldn't communicate, and the relative then said, you may have explained everything to the patient, but we didn't know all these things are likely to happen. Day of the surgery, at the OR reception, again, the identity of the patient is rechecked with the name tag by the receiving nurse. Name tag, it is correlated with the chart and the consent form, because you can have the consent of another patient slipping into another chart. All these things do happen. Recheck whether the site and side of surgery is marked. The patient is awake at that time. You can speak to the patient and find out what surgery he is going to go through, and check if the consent form is being filled and is there. Now, I just want to mention about this consent form. Initially, when an audit was done, this was many years ago, about the consent form, it was found that about 50% of the patients did not have a consent form when they went into theater. And nobody believed this. They said, no way, all our patients have consents done. So then this was relooked with the deputy MS in the theater at that time, with doctors involved, and to their surprise, the figure actually came even less. It was about 48%. And then the then director took a stand and said that no patient with a consent form, without a consent, will go into the OR. And then the compliance improved to more than 90%. Now, again, the timeout concept, we do it a little differently, where before intubation, the anesthetist is mainly involved, and then the surgeon gets involved. Now again, pointing out to that you don't need to strictly adhere to the WHO checklist, you have to change it to what your needs are. The sponge and instrument count is done before the wound closure, whereas on that checklist it is put in after the wound closure, before the patient leaves the OR. Other things are more or less the same. So finally, this is the checklist which is there in our hospital. Now it looks different from the WHO checklist, but the essence of the things are all there. And it is in one form, and so it's not many pages which need to be filled. And so if it is simple, it's more likely that it will get filled. And for our neurosurgery unit now, some things like these drugs are not mentioned in that checklist. So we have added on few things like that into this checklist. If you note that initially on that checklist they mentioned that the surgeons and everyone have to introduce themselves to each other. But in our setup, people are very familiar with each other, and usually you don't have any strangers in the OR, so there's really no need to introduce each other in the OR formally. You also might have a situation when you're starting off, if you have very senior surgeons who don't have a culture of introducing themselves, you should not sort of try and force just one point of that checklist and create an issue, rather than, bypass that and go ahead and make sure the remaining checklist is done. So it's important how this whole concept is introduced into the hospital. So finally, these are exact wordings from the WHO document. Some individuals will consider it a waste of time, and the goal is not to frustrate workflow. The checklist is important to introduce a value of patient safety. Implementation is not possible without sincere commitment by hospital leaders. People in the junior level cannot make this work. With education, barriers to implementation can be overcome. Thank you.